Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Stephen Gluck. He's a professor in the Division of Nephrology at UCSF. University of California, San Francisco. He's focused on acute and chronic kidney disease, electrolyte disorders, kidney stones, outpatient and home dialysis. So we're going to talk about that stuff. So, Stephen, thanks for coming.
Oh, sure, my pleasure.
Yeah. Tell me about your clinical work. What kind of patients do you see? And, we'll talk about trends and all that good stuff.
Yes, I'm a general nephrologist in the division. Quite a bit of my time is spent seeing outpatient dialysis patients. And that includes patients in what's called in-center hemodialysis, where patients go to a clinic several times a week, and also home dialysis, and that includes both peritoneal dialysis and home hemodialysis. I have an outpatient clinic 2 days a week where I see patients with a variety of different kidney disorders, high blood pressure, diabetic kidney disease, inflammatory diseases of the kidneys like glomerulonephritis, polycystic kidney disease, and electrolyte disorders of various sorts. And then I also do inpatient consulting at UCSF Medical Center, seeing inpatients with acute and chronic kidney failure and other acute and chronic kidney conditions that we're asked to consult on.
What are the biggest and baddest kidney conditions that you see? Are they diabetes related, or what's out there?
Well, the number one cause for patients needing to go on dialysis is diabetes, diabetic kidney disease. So that's by far the most prevalent serious kidney disease that any nephrologist sees. And it's a challenging disease. Even a lot of times, even despite all our best efforts, patients end up with progressive kidney disease and end up on dialysis. There have been some developments in the field recently that some new classes of drugs that are available that offer a lot of promise. But that's clearly the most serious of the kidney disease we see. But then we see a lot of acute renal failure in the hospital, for example, following surgery, gastrointestinal or thoracic surgery, or associated with acute medical illnesses. Sure, a lot of people have heard about kidney failure associated with COVID-19 infection, so we do see that. But we see kidney failure associated with other acute serious infections as well.
So, I don't know if people know very much about dialysis. What is it like? What does the process do? And, what are some of the basics for people that don't know?
Dialysis is, I guess the general term that's now used for dialysis is renal replacement therapy. So essentially it's therapies that are meant to replace the function of the kidneys when the kidneys aren't working. So the kidneys have a number of different functions. They control the volume and composition of what's called the extracellular fluid. The extracellular fluid is the fluid that's in our tissues and also in our bloodstream. So the kidneys control the electrolyte composition. They remove waste products. They control the amount of fluid so that there's not either too little or too much fluid in the system. And then they also have other hormonal type functions. For example, they make a substance called erythropoietin that's necessary for red blood cell production. They are responsible for converting the precursor form of vitamin D to the active form of vitamin D. And they have a number of other important functions as well.
So typical dialysis, a person gets it, 3 times a week, and it takes several hours each time to go and and have the dialysis done?
Yeah, that's right. Most patients who do what's called in-center hemodialysis go into dialysis clinic 3 days a week, and each treatment is usually between 3 and 4 hours long. During the procedure, the blood is removed from the patient. It's passed through a special type of filter, which allows waste products to go across it, but retains blood proteins and red blood cells. And then what's called a dialysating, sort of cleansing fluid, flows through surrounding the little capillaries that the blood goes through, and allows the waste products to pass across this membrane and be removed from the body. And then the blood that's cleaned is returned back to the patient. And then during that same procedure, the special filter is designed so that negative pressure can be put on it to draw fluid out from the capillaries and remove it, so that during the treatment, patient's blood is cleaned and also excess fluid is removed.
What constitutes the excess fluid? What's in it? Is it just water or other substances?
It's just tissue fluid. All of our tissues, or muscles, or internal organs, they're all bathed in a tissue fluid that medical terms is referred to as the extracellular fluid. And so that extracellular fluid composition has to be kept just right for cells to function normally. The sodium concentration has to be kept at a certain range, the potassium concentration, calcium, a number of other important minerals and constituents of the fluid have to be kept in a certain range to maintain normal cellular function. And most of that adjustment is carried out by the kidney.
So, okay, I guess it could also be interstitial fluid. Could it be called that?
Yes, it'd be interstitial fluid. That would be another way to describe it.
So in dialysis, what are the main parameters that they're looking at in the person, and what levels need to be adjusted? What are some examples?
Well, we look at a number of tests at least once a month, and usually more often. We look at the electrolyte composition of the blood, especially the blood potassium, blood bicarbonate, blood sodium. We look at waste products that accumulate in the blood. And the two main waste products we look at are urea and creatinine. The urea is a breakdown product of protein breakdown that takes the nitrogen that comes from protein breakdown and converts it into this relatively inert molecule urea and then in normal people that's just excreted in the urine. So that during dialysis, the urea is removed by dialysis. And creatinine it's less important as a waste product, but it's used as a marker for level of kidney function. Creatinine is a waste product produced by muscle that's excreted by the kidneys, and we use it. We follow the levels of creatinine as an indicator to determine if patients have a defect in kidney filtration function. That's also removed during dialysis. Then we have a number of other important tests that we look at. One is we look at the blood count in patients. So as I mentioned before, the kidneys make this substance, erythropoietin, that's necessary for red blood cell production. So that most patients with kidney disease develop a very significant anemia and need to receive injections or infusions of erythropoietin produced by pharmaceutical companies to replace the production by the kidneys and maintain the normal blood count. To look at bone metabolism, one of the important functions of the kidneys is to remove phosphate. That's a important component of the diet and is excreted by the kidneys, but in patients with impaired kidney function, phosphorus builds up in the blood and then can lead to a variety of different effects, such as bone disease and calcification of the blood vessels. So it's important that the dialysis removes phosphate. We also check on these secondary effects of the high phosphorus to prevent adverse effects from it. For example, one of the effects of phosphate is to stimulate the production of this hormone called parathyroid hormone. It's a hormone produced by little glands behind the thyroid gland called the parathyroid glands. Their principal function is to control the blood calcium level. When the blood phosphorus goes up, it stimulates these glands, and they can start producing excessive amounts of their hormone, parathyroid hormone, and that in turn can affect the bones and lead to bone disease. So that's another one of the tests that we follow. And we also follow patients' nutrition and a number of other indicators of general metabolic health.
So why is there excess interstitial fluid or extracellular fluid? Is it just because that normally would come out through urination, or is there an excess accumulation for other reasons?
Yes, you got that exactly right. The kidneys respond to sensors in the body that sense the amount of extracellular fluid. So in patients with normal kidneys, those sensors tell the kidneys to stop absorbing salt and water, and so the excess fluid that comes in from your diet, for example, gets excreted in the urine. But when patients have kidney disease, that sensing and feedback system is impaired, so the kidneys no longer excrete the amount of fluid to balance what's coming in, and that can lead to sustained excessive fluid in the body, and that can cause high blood pressure and other adverse effects.
So how much extra fluid in a typical dialysis session, how much fluid needs to be taken off and not returned?
Each dialysis patient, when they come in, the first thing that they do is they get weighed. And so the purpose of that is to determine how much fluid has been gained in between each dialysis session. So in each patient, we try to determine what's called a dry weight, and that's the weight where the excess fluid has been removed, but not too much fluid. So they don't have an excess, but we haven't removed so much fluid that they're actually dehydrated. So that each time a patient comes in, they're weighed, and then we look at the difference in weight between their dry weight and their weight in the clinic prior to dialysis, and that determines how much fluid is removed.
Well, are you removing it all through the blood, or are you also somehow able to collect the interstitial fluid through another mechanism?
All of it comes out through the blood. That's really the only access we have for removal of extracellular fluid is the bloodstream. I should say that's the only method for hemodialysis. There's another method of dialysis called peritoneal dialysis that we haven't discussed that doesn't require access to the blood, but for patients in dialysis clinics, it's all done through the blood. So
how would, wouldn't that be dangerous? Because the blood would get diluted with all this fluid that's not normally there, that's out of the blood into the interstitium. So, I think that would, the blood cell count in a given volume of blood would go down, I think, by, the density of it. All the factors in blood would be diluted by this, right?
Yeah, that's exactly right. One of the important things is we have to caution patients they have to be on fluid restriction, also salt restriction, to prevent excess fluid gain in between each dialysis treatment. Otherwise, they can have exactly the problem you outlined there. Their blood cell count can go down because of dilution, but even more importantly than that, it can raise the blood pressure, and then fluid can also build up, for example, in the lungs, and can cause shortness of breath and lead to a hospital admission.
So what happens in peritoneal dialysis? How is it different?
So in peritoneal dialysis, no blood is involved, and patients who do that have a catheter that's placed in the peritoneum. The peritoneum is a membrane that lines the intestine. It's sort of like a collapsed Ziploc bag, if you will. So you took a Ziploc bag and you kind of rubbed it between your fingers. You could rub one side of the bag over the other and be kind of slippery. Well, the peritoneum, it's a similar principle. The peritoneum lines the intestines like a collapsed sack and provides kind of a lubricating mechanism for the intestines to glide over each other. But it's a potential space. It's a collapsed space, but in peritoneal dialysis, fluid is put into the peritoneum and used as a method for removing waste products and fluid. So the way it's done is that the peritoneal dialysis fluid that's used has a very high glucose concentration. The glucose draws fluid out through what's called an osmotic effect. So if you want to understand osmotic effect, just think about if you put pure sugar on your tongue and your tongue feels kind of dried out, that's because the sugar draws water out of your tongue and kind of dehydrates the tongue muscle.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Well, these solutions that contain a high amount of sugar in them, glucose, do the same thing. The high sugar concentration draws water out of the tissues, and that's the way it removes fluid from the body. And then also the fluid itself has no waste products in it, so the waste products in the blood kind of leach out through this peritoneal membrane into the peritoneal dialysate fluid, and that so that the peritoneal dialysis removes fluid through the osmotic effect of the sugar, and then also removes waste products because of the concentration difference and the leaching of waste products from the blood into the dialysate.
It seems like there's not a very nice trade-off between the methods. Why not do a combination of a little bit of blood filtration and some peritoneal, so that you don't have to have this seesaw effect or this, forcing the waste products and everything through different pathways they may not normally go through.
It's an interesting idea. I have personally never seen any patient who was doing both peritoneal and hemodialysis, but what you point out is right. Each of the methods has its own advantages and disadvantages. The big advantage of peritoneal dialysis is patients do it at home. They don't have to be on a fixed schedule to go into a dialysis clinic. Most of the patients do it at night, so most of the patients on peritoneal dialysis have a little machine called a cycler that takes the fluid and flushes it in and out of the peritoneum during the night while the patient's asleep. So the patients basically have the whole day free. And then also, since it's done every day, in contrast to the hemodialysis where the treatments are only done 3 days a week. So in many instances, it gives the patients a little more leeway on their diet and the amount of fluid they can drink.
Yeah, with regular dialysis being done 3 days a week, you would get a profile of build up, release, build up, release, build up, release. And from what I've heard, when people have to take a lot of fluid, when a lot of fluid has to be taken off, they usually end up with, maybe heart issues temporarily or faintness or other issues. So it seems like the more often the better. But then again, there's the trade-off of all the time spent and, the method of dialysis as well.
Yeah, that's true. You're right. Ideally, you'd want to do the dialysis every day, just to more closely simulate the functions of the kidneys, which are removing fluid 24 hours a day. But and if you think about it, patients who go in for dialysis, they're having all of the fluid they gain for 48 hours or more removed over a 3-hour period. So you're right, that does put a big stress on the cardiovascular system, and it's not uncommon for patients to have a drop in their blood pressure and to have symptoms feel terrible or have cramps or sometimes even faint if too much fluid needs to be removed. So that is an advantage of the peritoneal dialysis, that the fluid is removed over a longer period of time, 8 hours per day, and it's done every day of the week, which tends to put less stress on the cardiovascular system.
Yeah, but again, who would want to do that? What happens to the ureters and the bladder and everything, and the tube going through the penis, the tube going through the vagina right to the end? I mean, if no urine goes through it, what happens to it, to the whole plumbing?
That's a good question. Amazingly enough, they remain functional. So patients with even no urine output still their urethra, which is the tube you're referring to, stays open, and then for example, if they get a kidney transplant, even years after they've stopped making any urine, it's still their bladder and urethra can still function completely normally.
So for people that don't produce any urine, do they have a protocol where they cycle fluid through them so that they don't, the tissue inside doesn't, I don't know, what happens to it? What happens to a bladder that's not used for years?
It just stays collapsed, or it's a little bit of fluid that's sometimes secreted into the bladder, but the urethra, the urinary passageway stays open, and the bladder retains its ability to contract. So even after patients who, even patients who've had no urine production for years, once they get a kidney transplant, can still have normal bladder function and normal urethra.
Is there any need to periodically, again, cycle fluid through there? Like
No.
flushing the system, or no?
No, there's no need to do that. I was just going to say, in fact, we like to avoid any type of procedures that, for example, catheterization or anything for patients who make little or no urine, just to avoid possibility of introducing bacteria that could cause an infection.
It must be weird if you haven't peed in years and then all of a sudden you pee for the first time. Have you ever talked to patients that do that, and do they tell you anything special?
Yeah, actually they do say exactly that. They say I've heard quite a few patients after they got a transplant remark about how wonderful it was to feel the urge to urinate again.
Yeah, that's crazy. What's some of the new protocols or things that are going on around dialysis that are helping people?
Well, dialysis technology is constantly evolving and improving. So there have been a lot of changes over the years. The dialyzers themselves are getting more efficient at removing waste products. The waste products that are removed are of different sizes. Some of them are very tiny molecules, some of them are larger molecules. But the composition of the membrane has changed over the years to allow removal of some of the larger molecules, and that prevents some of the long-term complications of being on dialysis. We're getting better about understanding what the limits are of fluid removal and trying to work with patients to limit the amount of fluid that they gain between treatments to reduce some of the complications we talked about excessive fluid removal. And the dialysis machines have some newer sensor technologies, like, for example, one of the newer technologies that's starting to be more frequently used is something called a crit line or hematocrit line that monitors the blood concentration as you do dialysis, and that's another way to be alerted whether someone's having an excessive rate of fluid removal. There are the newer dialysis machines also test for the equivalent of the urea concentration of the blood, so that we have an idea of how well the blood is being cleaned during the course of the dialysis, as opposed to having to wait for blood testing to be done to determine that. So for dialysis, there's a number of different advances in dialysis technology, and it's a constantly evolving field.
And then we haven't talked about it much, but what are the other major renal issues that people have, and why?
There are many different causes of loss of kidney function and ultimate need for dialysis. We talked about diabetes being by far the most common cause of kidney failure. The second most common cause of kidney failure is high blood pressure, uncontrolled high blood pressure. And third is a category of diseases called glomerulonephritis. So glomerulonephritis that word comes from the word glomerulus. Glomerulus is the medical term that's used for the little filters in the kidney that filter in the kidney tissue that actually filter the blood. And when they get inflamed, we call that glomerulonephritis. The itis suffix indicates inflammation. There are a whole variety of different causes of glomerulonephritis. For example, lupus, which is an autoimmune disease that some people may have heard of. That's one of the more common types of glomerulonephritis. Worldwide, the most common type of glomerulonephritis is a disease called Iga Nephropathy. That's IgA is short for immunoglobulin A, which is one of the blood antibody types that was involved in fighting infections on tissue surfaces. And in the disease Iga nephropathy, it gets deposited in the kidney filters. The glomeruli causes inflammation and can lead to kidney failure. There are a number of other types of glomerulonephritis, too numerous to mention here. I could go through a whole list of names of them, but some of them are what we call primary glomerulonephritis, where there's no underlying cause for it that can be identified for it, and some of them are what are called secondary glomerulonephritis, which are nephritis that's associated with an underlying systemic disease. Like, for example, hepatitis, either hepatitis B and hepatitis C, can frequently affect the kidneys because of the inflammation that's associated with the hepatitis, and that can lead to progressive kidney disease. Or other chronic infections can lead to inflammation in the kidneys, like, for example, tuberculosis or other chronic infections. So that's just a small part of the huge list of causes of glomerulonephritis. Then after that, we have a variety of genetic diseases that can cause kidney disease, which are the most common one of that would be polycystic kidney disease, which is a disorder that's where the kidneys are filled with enlarging cysts that over time replace the normal kidney tissue and lead to complete loss of kidney function and then frequently the need for dialysis. But there are a number of other genetic kidney diseases that can also affect the kidneys, like, for example, congenital developmental abnormalities of the kidneys or the spinal cord that can lead to kidney disease and a number of others.
So, I don't know, what the big developments in kidney function are going to be, around dialysis, or what areas do they seem to be focused in?
We have not really had a lot of effective treatments for kidney disease, for many kidney diseases. Some of the glomerular diseases I mentioned, there are for some of those diseases, there's some very effective treatments, so that's one exception. But for a lot of diseases, like, for example, mentioned diabetic kidney disease or a lot of the other causes of kidney disease, we have some agents that are effective for slowing down the rate of kidney disease, but don't prevent the ultimate progression to need for dialysis. But there are some promising new developments that are coming out that might offer us actual medications to allow us to really slow the progression of kidney disease down a lot and hopefully keep some of these patients off of dialysis. So, for example, one of the most important ones that's come out recently are a class of drugs called sodium glucose cotransporter 2 inhibitors. So it's abbreviated as SGLT2 inhibitors. Those are the sodium glucose cotransporter. It's a protein in the kidney that takes the glucose that's filtered by the kidney and allows the tubules to reabsorb the glucose so that it doesn't go out into the urine. And these drugs block that transporter, that protein that's involved in the glucose reabsorption. And it turns out that a number of studies have been done now that show that it has a dramatic effect on reducing the rate of progression of kidney disease, and also has other very beneficial effects, like, for example, preventing against heart disease. So that's a very important new development in the kidney treatment field. And then there's some other medications that are under development now to look at that are designed to inhibit scar tissue from building up in the kidneys, and we probably will be seeing those being approved and starting to be incorporated in nephrology as another way of preventing progression of kidney disease.
Very good. Well, what's the best way, Steve, for people to find out more about your clinical work and to find out about kidney disease in general? Where can they go?
UCSF does have a website that has all the UCSF faculty, including me. That's one way. Or people can. I don't have a personal website available for contact, but anyone who wants more information or who wants a consultation or would like to discuss any of this with me can reach me through the UCSF nephrology website.
Okay, well, very good. Well, Stephen, thanks for coming, and I appreciate it. It's been a good call. Thank you.
Okay, thank you so much. I really appreciate it, the opportunity to speak to you today.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.